We're just getting started. And we are live on Instagram as well. Perfect. Hi, everybody. Just waiting for everyone to sign on, getting everything ready to go. It's great to have you all back. Welcome back to Fertility Fact or Fiction, where we review on a monthly basis all of the hot topics in infertility, try and give you some education, and then answer all of your questions live. I am going to do my best to stay sharp tonight. I was on call last night delivering babies, so it was quite a busy night, but I will do my best. We are also starting a new series called Fertility Basics, little short video clips that'll be on our Facebook page and our YouTube page, and we'll probably throw them into some IGTVs on Instagram. And those are just the basics of infertility, so you can learn about the essentials, know about the very simple things, and the real casual, short little blips that we talk about for everyone to know. So make sure you like, make sure you subscribe, lots of comments, and we will take all your questions. I want to make sure that we have sound as always. So can those of you watching on Instagram tell me if we have sound? Just give me a thumbs up for sound, please, if we have sound on YouTube and Twitter and Instagram. Getting some really great questions already. Hi, Alana. I hope you're well. Thanks for saying hello. Sound, please, if we have sound. We got sound. I can hear myself on my on Tarek's phone here. So, okay, good. Oh yeah, lots of thumbs up. Excellent. Okay, guys. So we're getting lots of great questions already. We're going to do the usual thing and just take the first 5 minutes to blab a little bit while we wait for everybody to sign on. And we're just going over everything. So a couple of sort of housekeeping issues. It does look like the fertility centers will be reopening soon. There was a rumor that the government in Ontario was asking us to wait an extra week. I think by the time everything really gets up and running, it's not going to make any difference. But we have started seeing our patients and letting them know that they can slowly start coming back in for doing insemination. And for IVF, we are getting the lab ready to go. We're currently in mouse embryo phase, so those are being tested to make sure everything is working perfectly. And then we will make sure that that's okay. Once that's okay, we are good to go for transfers, actual retrievals. We just finished an amazing video today dedicated to getting the College of Physicians and Surgeons to say yes. So hopefully we'll be able to submit that this week, and hopefully they will give us permission because they can't come out to do inspections right now. Otherwise, we are good to go at the Create Fertility Center in Toronto, which is one of Canada's largest fertility centers, and we will be able to help all of our clients through that means. So very excited about all the new changes and all the new things that are happening. It's the closeout of Nurses Week last week. Again, a huge shout out to all of our nurses and frontline workers who have always helped and always been part of our practice. And now more than ever with the COVID-19 going on, all the work and effort that you guys are putting in is tremendous. And on behalf of all of us, thank you to all those of you who have made such amazing sacrifices and effort on behalf of all the patients out there. Okay, so I think we have a pretty good crew collecting. So I am going to get started on this week's Fact or Fiction. So this week, the topic that I decided to go over is about whether or not we should use a single or a dual trigger when triggering patients for in vitro fertilization. So let me go through the basics because you need to know a little bit about the history. In order for your egg to release, it has to receive a signal from your brain or artificially in the case of IVF to indicate to the egg that it is time to leave the ovary. And from the kind of onset of IVF, the trigger that was used is actually the pregnancy hormone called HCG. So when we give people HCG, it acts like your body's natural LH, luteinizing hormone, because they're very similar. And it actually tells the ovary to release the egg. The good news was it worked quite well. The bad news was for some patients, what ended up happening was they developed ovarian hyperstimulation syndrome. What's that? Well, if you have a high number of eggs, you're a strong responder. Your ovaries can kind of go into overdrive. They start making tons and tons of fluid. You start leaking fluid from your blood vessels. Your belly fills up with essentially something called ascites, which is a fluid that's secreted from all the tissue surfaces inside your belly. You can get quite sick from it, even intensive care admission, and it is not comfortable. The ovaries are huge, it's painful, you get a lot of nausea, diarrhea, you're at risk for forming blood clots, and you can have multi-system involvement with your kidneys getting weaker, your liver getting kind of inflamed, your blood getting thicker to place you at that risk of blood clots. So people started finding alternatives to the triggers, and then they moved into using a different type of trigger, which is called a GnRH agonist. So that's a hormone essentially that your brain produces, which is sort of the grandfather of the hormones. That's the one that comes from your hypothalamus that goes to your pituitary to tell your pituitary to make the hormone that tells your ovaries to produce estrogen and progesterone eventually, or in the case of testicles, to make testosterone. So people started using the GnRH agonist because they found that it eliminates or almost eliminates the chances of ovarian hyperstimulation syndrome. Then people started wondering, well, what if maybe we use both? Does it make a difference? And so a lot of research has gone into this, and there are several studies now that review whether or not a single trigger using just HCG or a double trigger using HCG and the GnRH agonist can be helpful. So the most important one I want to review is a meta-analysis. So you guys know that we've talked about meta-analysis before. That's where they take all the different studies on the subject, they kind of pile them together, and then they pool the data so that they're getting one bigger study. And with that, they can kind of figure out what sort of results are we getting to important questions without having to conduct an often impossible to conduct very large study. It's hard to do those in infertility because patients obviously don't want to be gambling, taking chances when they're dealing with high costs and, high stress situations. So pooling studies together data-wise is an easier way to achieve those answers. So this is an interesting meta-analysis. It's actually a little bit older, but I'm going to include some newer data as well. So here's where some knowledge about meta-analysis is important. So first they studied just all articles that they could extract looking at dual triggering. So they actually found 743 articles that initially met the criteria. So when they looked at the individual studies, they found 226 of them were duplicates, which got them down to 517. And then they excluded 494 of those because they realized straight off of the title and the abstract that they weren't appropriate for the actual study. They ended up with 23 articles, of which 19 got excluded because they actually didn't have a dual trigger. Or they were not a randomized controlled trial. So this meta-analysis included only randomized controlled trials, which is the halo study that we look for when we're trying to answer questions. So they narrowed it down from 743 initial finds to 4 studies that met the criteria. The good news with something like this is you're focusing on the exact question and you're only using the best data. So hopefully the answer becomes really valid. The bad news is you may be missing some studies in there that could offer some different opinions or shed some more light on subjects, but they're not done as rigorously. So the quality of that evidence is a little bit more suspect. So when they did these studies, they actually looked at multiple different outcomes, and I'm going to go through each one. So the first thing they looked at was the number of mature eggs that you retrieved from the cycle. So is there a difference in how many mature eggs you're going to get? And what they found was that there was no difference in the two groups between the number of mature eggs. So there was no statistical difference between whether you got a single HCG trigger or the GnRH agonist and an HCG trigger. So then they looked at fertilization rate. How many of those mature eggs, when fertilized, actually became embryos? And they actually showed the same thing again. There is no difference between the HCG and the GnRH agonist and HCG triggers. What about the usable number of embryos on day 3? Again, no difference. Now, unfortunately, they didn't look at the day 5 data, and that's what we normally are using these days. But for the day 3 study, again, they showed no difference in the outcomes. So then they got down to the number of embryos associated with implantation. What was the implantation potential? And again, they showed there was no difference in the implantation potential of those embryos either. So your implantation rate, which means that you're getting a positive beta HCG blood test, again showed no statistically significant difference. Then they looked at pregnancy rate. So that's defined as seeing a heartbeat on ultrasound around 6 weeks. And when they jumped into the clinical pregnancy rate, you're now seeing a 55% increase, and that was highly statistically significant. So if you were getting the dual trigger, excuse me, with the GnRH agonist and the HCG, you actually had a 55% increase in your success rate. And any of those of you who have worked with us at the Nahal Center know when we triggered patients that had anything above like sort of 8 to 10 follicles, we typically would trigger you with the dual trigger. So we would use the GnRH and the HCG trigger. And this study is saying if you use both in those situations, you can improve the outcomes. Why? Well, there's a couple of different reasons. The authors hypothesize that number one, in your endometrial lining where the embryo is going to stick, there's probably some receptors that help you to actually improve the quality of the lining of the uterus to give you a higher chance of implantation. That's using the HCG component. From the GnRH agonist component, when you first take a GnRH agonist trigger, the interesting thing is that it gives you a little blip of increase in both your natural FSH and LH. And if you look at a natural ovulation cycle, when you're getting ready to ovulate, you actually do have a small rise in your FSH level, and taking the GnRH agonist can mimic that. So it's getting it as close to natural, and that also probably has some final impact on the maturation, on the quality of the eggs, and on the quality of the lining. So that's the hypothesis behind it. We're actually looking, just as I'm doing this, at some patients that are asking questions. And the answer is a HCG trigger is the same thing as Ovidrel, although we typically do not use Ovidrel for our IVF cycles, but we do use it in our IUI and our natural trigger cycles. So yes, it is the same medication. And a GnRH agonist, typically the one we use is Lupron. So there's another study done more recently. This one was 2019. And in this study, the authors looked at the number of eggs that were mature. Did you get a higher number of mature eggs? And although it's a really very sort of low-key result, they did show that there was a higher number of mature eggs when you use the dual trigger versus the single trigger. This is from the Journal of Obstetrics and Gynecology, and the study involved patients that were doing IVF. They had 137 patients that had a standard HCG trigger and a dual trigger, and they looked at all of those and then compared the ones that had the standard trigger against their own cycle when they did the dual trigger, and showed with the dual trigger they got one more egg. So just a little bit of a hint of egg number. There's yet another study done in reproductive biology and endocrinology. And in that study, it was quite interesting. So 427 completed cycles with fresh embryo transfer. And they looked at women that actually had diminished ovarian reserve. So now instead of taking the patients that are the super high responders, where we worry about them and are concerned that they may develop this ovarian hyperstimulation syndrome, they said, well, hey, maybe if it's good for them, it might be good for poor responders as well. So when they looked at it, they defined the poor responders as women that had either less than 5 follicles at the start of the cycle or a low anti-Müllerian hormone level of less than 1.1 nanograms per mil. So when they did that, they compared 130 patients who got just the HCG versus 297 who got HCG and they got the GnRH agonist. So very interesting results. The dual trigger group, even though these are women with poor function in their ovaries or ovarian reserve, had a higher fertilization rate. So 73.1 versus 58.6. They had a much higher clinical pregnancy rate of 33% versus 20.7%. And even the live birth rate was increased, almost doubled, 20 to 14.5%. So again, in a group where traditionally your results are really hampered, getting a 26.9% success rate for live birth is actually quite incredible. So it does look like there may be some hope for this dual trigger. So that is really quite fascinating and important information to consider, because now it's extending beyond just the patients who have the high responders. It's actually involving the low responders too. In this particular study, they compared the two groups. They showed that they did not have any differences in their sort of demographic criteria or in their AMH levels or BMI or age or anything like that. And they had some real interesting breakdowns of the specifics, and I want to share those with you. So cancellation rate of embryo transfers, 15.4% in the single, 6.1% in the double. So almost 1/3 the number of canceled embryo transfers. Implantation rate, 10.6% in the single and 15% in the double, and those were not different between the two. Clinical pregnancy rate, which I told you about already, 20.7% in the single, 33% in the double. Live birth rate, 13.1% in the single, 27.2% in the double. When they looked at the abortion rate, and this has not been shown before, they showed a more than half reduction in the rate of miscarriage. So in the group that got just HCG, they had a 37% miscarriage rate, which is really unfortunate and obviously and very high. So that's concerning. But in the group that got the double trigger, they actually only had a 17.4% miscarriage rate. Now that's still substantial and obviously something we want to avoid. But considering they've cut it in half, that's very, very important data. So all of these things are looking, or at least suggesting, that the use of a double trigger seems to improve your success rates in many different facets, including reducing miscarriage while also increasing live birth. And it's no longer just good for the women that are high responders. Now there's evidence that it's actually potentially good for everybody. One more quick study, if this stuff hasn't convinced you. There's another study, very, very recent, just showing that from 2020 actually, showing the title Dual Trigger Using Recombinant HCG and Gonadotropin Releasing Hormone Agonist Improve Oocyte Maturity and Embryo Grading for Normal Responders. So these are not the high-risk patients in GnRH antagonist cycles, and it's a randomized controlled trial. So what did they show? They showed, and I'll just review that data with you as well. So if you look at their numbers, essentially the reproductive outcomes. So the chemical pregnancy rate was 3% in the HCG group, and then the dual trigger group was 1%, no difference there. And when they went through all of the reproductive outcomes actually in this study, they saw that there weren't any significant differences until they got to frozen embryo transfer. So in that particular study, they didn't see the fresh embryo transfer differences for any of the outcomes: chemical pregnancy rate, clinical pregnancy rate, live birth rate. But when they looked at frozen embryo transfers, huge differences. So 25% of the HCG group had a clinical pregnancy following a frozen embryo transfer versus 45.5% in the dual trigger. When they looked at live birth rates, it was 12.5% in the HCG group, which admittedly is low, so that makes me a little bit suspicious. But it was 45.5% again in the dual trigger group. So the live birth rates are much, much higher when they're having frozen embryo transfers, but they actually received a dual trigger. I looked really hard for another study. It was published in Fertility and Sterility, I think about a year or two ago, which actually showed the exact same thing, demonstrating that if you took a small amount of HCG at the time of your GnRH agonist trigger, that if you were doing a freeze-all cycle where all your embryos are getting frozen, you would actually improve your success rates with the frozen embryo transfers. And because of that, we adopted that technique a while ago and have been using that on all of our patients. So now we're going to be applying that to more than just the patients that are high responders. We're actually going to double trigger everybody. The big question is there a risk? Well, yes, there is. So even that small amount of HCG can lead to a higher incidence of ovarian hyperstimulation syndrome. Is it a risk worth taking? I believe it is, because it looks like the data is supporting a very robust improvement in the success rates and then that decrease in miscarriage risk. But nevertheless, you will need to go into it knowing this does increase the potential for complications. So I'm going to flip out of that. The fact or fiction tonight was, is a dual trigger better than a single trigger? And it is a fact. A dual trigger is better than a single trigger. So fact or fiction tonight is really important because you should be getting a dual trigger regardless of your ovarian reserve status. So the high responders should, the normal responders should, and even the poor responders are showing a benefit to doing that. Okay, so I want to go through some of the questions. I did promise one patient online that I would answer the question of multiple cycles having been done, with really the only change being different medications, and in one cycle using the platelet-rich plasma or PRP therapy. So I want to give a shout out to that patient. Thanks for asking the question and communicating with me. I understand you're watching tonight, so hello there. So a couple of things that are really critical for you to know. Number one, it's really important to know that the dual trigger is important based on what we've shown here. In terms of other things that can be done to assist your cycle, simply changing medications very rarely makes a difference. So that is not a technique that we use here. We actually stick to our kind of tried and true approaches to things, and I'm certainly willing to alter when we know a patient responds better to one drug than another. But just basic changes from like going to left to Follistim, or from Follistim to any other product, Puragon or any of the other ones, it doesn't make enough of a difference to be substantial. There are differences between recombinant and urinary products, and there is some data suggesting that you need a certain ratio of the recombinant to the urinary to get the lowest number of abnormally karyotypes, so genetically abnormal embryos, by balancing correctly the right ratio of the urinary to the recombinant hormones. But there is no evidence that simply changing from one to another makes a difference. As far as PRP is concerned, the platelet-rich plasma, there is no good evidence that that works. There is some data that we reviewed in a previous Fertility Fact or Fiction. It's available on our YouTube channel for you to review. Make sure you like and subscribe, showing that there is some suggestion that it may be beneficial, but it was a fiction that it actually worked, because we couldn't tell for sure. There is not enough good data to support the use of platelet-rich plasma. The other aspects or other things you can do. So number one, I think it's important to make sure your vitamins are adequate. Number two, there are sort of psychological determinants which can assist you. So we spend a lot of time working with that with our patients. The DuoStim protocol has been shown to be helpful. And then there are medication combos, as I said, that you can use that can be beneficial in terms of the ratio, but not specific medication changes. There's a whole host of other things that we try for our patients as well. DHEA has been proven to help you make more eggs, although it's not associated with live birth. Human growth hormone, however, is associated with live birth, and that also can be beneficial for you in terms of increasing your chances. Finally, she asked us about whether or not a natural cycle can be beneficial. So we do like natural cycles. I've done them quite a bit for patients that are not doing well in a conventional cycle. I think it sort of behooves everyone to be individualized. If you're doing cookie cutter medicine, I'm never really a big fan of that. Everybody needs their own individualized plan and care. Is a natural cycle right for you? I really need to sit down, look at all your values and your data, and then decide. But if you've only made one egg, taking tons of medication and lots of shots and all the stress and the cost, you can make one egg just with a natural IVF cycle, and the costs are way lower. So our costs are 6,000 Canadian for Canadian residents, and I think it's just around 7,300 for non-Canadian residents. And so for roughly about 5,000 US, you can get a natural IVF cycle, and the meds cost only about $500 or $600. So it's a very reasonable approach for people that are only producing one egg, because the costs are way lower, the hassle is way lower, the stress is way lower, and you're getting the same outcome anyways. So I just wanted to make sure I addressed her question, because I thought it was good for everybody to know about that one. Do you have some questions you want to read out? Yeah? Okay. Tarek's here again, and he's going to ask me some questions. Somebody asked me about my kidney stones. I am 100%. Thank you to Dr. Tom Decly, who saved my kidneys and my ureter and my life. So thanks, Tom. I love you, buddy. Yep.
Chance of false positive HCG line is AM stark white, PM very dark double line. Next, AM stark white.
So basically, what's the chance that your fertility predictor, your ovulation kit, is false positive? It depends on your specific scenario. So for example, if you have PCOS, it can be false positive because your natural LH level can be high, and it's actually reading a breakdown product in your urine of LH. So they can be inaccurate, but typically if you look at the product monograph that comes in it, it should tell you how successful it is. And Tarek and I are actually going to do a review of products for you shortly online. We're going to sit here and open up the packages and kind of do one of those review shows. So most of them are pretty accurate, anywhere from about a low of 93, 94 to a high of about 97, 98%. So they are fairly reliable. And if it did show a positive, it's usually reasonable to assume you are positive. If you're worried or concerned, obviously the best way to test is to come in for testing, which would be ultrasounds and blood tests. And you actually don't want to just see the LH rise. You want to see that you've subsequently started producing progesterone, because that's really the proof that you have released your egg. Yeah.
Okay. Are there any specific diet changes to make before IUI?
Yeah, so we talk about diet all the time. It's on pretty much every one of our FFOF shows, but Mediterranean diet is recommended, low cholesterol, low sugar, lots of vitamins. Dietary changes are simple. You want to have a very reasonable caloric intake. If you're on a high calorie diet, that's not good unless you're very thin. And if you're on the heavier side, then definitely you want to reduce your calories in order to help with weight loss, because that can improve your success rates. You want me to take a Facebook?
You want to go ahead?
Yeah. How closely do you monitor currently pregnant women who have had previous miscarriages? That's a great question, Val. What's the earliest you do ultrasounds, and how often is beta tested? So there's a pro and a con to the close monitoring. So keep in mind that early on in a pregnancy, we have absolutely nothing we can do to alter the course of the pregnancy. We put all of our patients on aspirin and progesterone, so we're kind of doing everything we can ahead of time. And I think that does help, and there's some proof to that, and we've even reviewed some of that stuff on the show. But actually doing the monitoring, measuring your beta HCG levels, or doing early ultrasounds makes absolutely zero difference to your outcome. Having said that, to reassure patients and set their minds at ease, we do monitor. So we'll do several beta HCGs just to make sure that it is rising appropriately, which is a minimum of a 60% rise every 48 hours. And then the earliest you really want to do an ultrasound is right at about 6 weeks. Now, if you have a very good ultrasound, which we actually have 2 of, you can pick up a fetal heartbeat at about 5 weeks and 5 weeks and 6 days, assuming you're very accurate. Otherwise, in the 6th week, for sure, we should be able to see a sac, a fetal pole, and a positive fetal heartbeat. So yeah, we do measure. Is there anything you would recommend taking to men and women before IVF retrieval and vitamins? Yeah, so lots of healthy living. So no smoking, no drinking, no alcohol, no drug use whatsoever, including marijuana. It's terrible for your fertility. Again, weight loss is important. The Mediterranean diet has been proven to be beneficial. Melatonin has been proven to be beneficial. We have a show on that. Vitamin D is critical. I've got all sorts of posts on the importance of vitamin D. It actually reduces miscarriage risks. Low stress is important. It can actually improve your success rates. And I say this every show, but we have, I think, the best program in Canada and maybe even in North America to support our patients' mental health and stress levels. So make sure your program, wherever you're working with, is there to help you and to support you through the process. Yeah, fire away.
Okay. It's a good question. They all are, but
yeah.
How do I thicken my uterine lining to improve
thickness? I saw that question. So how can you improve the uterine lining? Okay, so there are some things that have been proven to improve your uterine lining. So number one, vitamins. So vitamin E and vitamin D can thicken your uterine lining. Aspirin has been shown to be beneficial. Vaginal Viagra can sometimes help. And then there is some evidence, including a very recent study, which did show that the platelet-rich plasma can improve the thickness of your lining. So that doesn't have any evidence for working in the ovary, but it may work in thickening the lining. The only other thing that has been used is something called GCSF or GM-CSF, which is granulocyte macrophage colony stimulating factor. It's super expensive, but that has also been shown to be beneficial. Sometimes it's just using a different approach. So frequently, if we try to help someone out with, let's say, oral estrogen and their lining doesn't thicken, we'll try vaginal or a combination, or we'll switch to patch. Some people just don't absorb it the same. So it's important to, look at the whole picture and try every sort of trick that you can. Yeah.
Next question.
Yeah.
Okay. Can you naturally unblock your tubes?
Oh, I saw that one. There is absolutely no way to naturally unblock your tubes. So if you have blocked tubes because of scarring or previous infection or damage, including endometriosis, there is not a single natural substance on earth that will unblock your tubes. I see all this stuff online, and we're going to do one of the review shows on that too, about applying stuff to your belly or to, take these herbal things in your vagina, these little herb balls that people are putting in their vagina. I've heard of this new protocol called vaginal steaming, which has actually been known to injure women. There are burn cases from doing that. So none of that stuff has a speck of truth. You cannot unblock tubes. All you need to do to convince yourself of this is type the word hydrosalpinx into a Google search and then click on images. For those of you that aren't squeamish, please don't blame me if you are. It's surgical pictures that you'll see. It'll show you what a damaged fallopian tube or a blocked fallopian tube looks like. If you can find something natural that unblocks that, I will happily submit a Nobel Prize, application on your behalf. There is nothing that will unblock damaged tubes. Once they're damaged, it is very, very difficult to even surgically unblock them, let alone by taking an herb or steaming something. That stuff is just nonsense. Let me take a Facebook. Hey, Crystal, 35 and 4 had been testing every urine with strips for protein. About 20% of the time it shows protein accompanied by high blood pressure almost every day. What can be done about this? Baby aspirin helps. And aside from that, if it's preeclampsia, nothing can be done about that. So we just have to keep an eye on you and watch you really carefully. The good news, you're 35 and 4, your baby is fully formed, so there is nothing really significant to worry about. But the concern would be that your blood pressure can get out of control. So if you have headache, visual disturbances, pain on your right side, kind of under your breast where your liver is, you need to go to the hospital immediately, and do not take chances if you have any of those symptoms, or even if you just notice your protein is getting higher or your blood pressure is getting higher, make sure you go and get checked out. It's always better to be safe. Will we be receiving emails this week regarding embryos coming from Toronto? Yes, no, and maybe. So we are in the process of doing that. In order to save everybody, hopefully, tons of money, we are trying to get the cryo shipping company to send us a great big tank where everybody's samples can come together. And instead of each person paying hundreds of dollars, everybody would pay very little because the whole shipment would be probably a couple thousand, but we have lots of people involved so that every person is only paying a smidgen. The problem with that is they only have insurance for a specific amount, and it wasn't per person, it was per shipment. So we are waiting for the insurance company to give us a number. I promise you I am on this on a daily basis. The minute I know, we will be broadcasting this out to you so we can get it back to everyone, let them know, and start getting the consent forms. If we have not gotten a firm answer by Friday of this week, we're going to just start shipping them one by one. It'll be a little bit more pricey, but probably not substantial enough in the long term to make a difference. So you will know as soon as we know. Yeah.
Is there hope of pregnancy for someone with low AMH? Mine is 0.29.
There is always hope. No one should ever take your hope away. 0.29 doesn't tell me enough because I need to know if it's nanograms per mil or picomole per liter. Sure, if your AMH is low, it is more difficult, but I will never tell anybody that they cannot get pregnant. We just tell you what your chances are. Sometimes it is low, so you need to know that. And as long as your fertility specialist is honest with you about your chances, I think it's really up to the patient to decide what's best for them. I'd love to know what you guys think. I actually posted about this, probably 7-8 months ago about, should I as a fertility specialist be telling you when enough is enough? And my opinion is my job is to educate you about your chances. Your job is to decide what's right for you. I don't think I'm in a position to judge anybody or what's best for them. But there are patients that get kind of addicted to this. So yeah, certainly we're vigilant and we won't lead you astray. But I think you need to know what your chances are. And if, a 20% chance is acceptable, you want to go ahead, that's great. And if a 5% chance is acceptable for you, I'll probably spend some time talking to you about it because for me, that's low. And even 10% is low. But if it's comfortable for you and you want to try, I am not the person that is going to tell you no. I'm the person that's going to give you 1 billion% support to let you go through whatever process you feel is right for you. Would the dual trigger be helpful for an IUI as well? So not one single study came up for IUI. It may be. There's no reason to believe it wouldn't be. So it might be a reasonable thing to do. If you have coverage, then it's great. And I know you do. So we can certainly try that for you. If you don't have coverage, it does add considerably to the cost. So we got to be a little bit cautious. Hi, I had a anal fistulotomy last week, and I'm just waiting for my cycle to start for FET after a long Lupron protocol. Would you still go on ahead with the transfer? I've been on 5 antibiotics in the last 6 weeks and pain medication to get me through this. Yeah, no, absolutely not. Do not try. Your body's inflammation will be tremendous, and we know that what's called the microbiome, so the natural bacteria that are in your vagina and in your uterus, are very critical to the success of achieving pregnancy, extremely critical, in fact. So if you've been on 5 antibiotics in the last 6 weeks, you will have absolutely altered and very likely detrimentally altered the composition of the microbiome, and therefore you absolutely should not be trying. If they are telling you you should, you need a second opinion. Can I talk about HGH, human growth hormone, and how this may be helpful for a poor responder? Okay, so there's this thing called the Cochrane database, and the Cochrane database is a very structured way of doing meta-analyses, which we discussed at the start of the show, where they analyze different topics. They do have one on the relationship between human growth hormone and IVF outcomes. And in that meta-analysis, it did show that it increases live birth. I'm going to tell you that I don't think anybody yet knows how, but it has been proven to increase live birth. I've only used it twice. Both times it did nothing, but they were older patients. And so I'm not sure that that is necessarily the right candidate for it. It does help you increase the chances. So they obviously wanted to try it because they wanted to improve their chances. But I think you really need to be using it in younger patients, maybe with diminished ovarian reserve versus the older patients with diminished ovarian reserve. You got more questions?
No, that's pretty.
Okay, let me see if I got anything up here. Is there maybe I passed one? Nope. Okay. Is there a chance you can fall pregnant, you can get pregnant with PCOS after having your tubes flushed with saline? Are you more fertile for a period of time after this? Yes, you are definitely more fertile after a saline infusion sonohysterogram. I'd say probably about 10% of our patients actually get pregnant just from our testing alone. However, PCOS, where your ovaries typically are not functioning properly, will not allow you to release an egg. So I can have the clearest tubes wide open, but if no egg is coming through them, it doesn't do anything for you. So the saline infusion sonohysterogram will help if your tubes are plugged, but it won't do anything for the PCOS patient unless they also happen to release an egg that month. So hopefully that answers that question. RCT, great. Oh, good. I'm glad you got that RCT, Morgan. That's good. Single trigger is usually Ovidrel, right? I think I answered that one already. Can you request that with the government program? Yes, you can request double trigger with any program. That's medication. It has nothing to do with which program you're going through. Thank you for sharing this. I have diminished ovarian reserve. Yep, that was the one you read me. Which HCG trigger do we typically use with IVF, if not Ovidrel? We use Pregnil. It's just actually HCG. I love Serono products. They make great products. I have nothing against Ovidrel with our natural triggers all the time, but for our IVF cycles, we like to be able to titrate how much we're using because we're now using this dual trigger. So you want to only give 1500. It's a little bit harder to do that with Ovidrel, which comes pre-filled. I can actually manage it much more easily with the HCG. And so that's part of why we do it that way. Can you talk about Ovidrel? There you go. What are the chances of ovulating before or after the IUI 36 hours after? Or is there a chance it won't work making you ovulate at all? Ovidrel has about a 97% to 98% ovulation rate. So it typically does work. Can you ovulate sooner? You can. It depends on what's happening with your body and what your specific sort of physiology is. So if you're PCOS and you need a trigger, you're not likely to release your egg before 36 hours if you are in need of something to trigger. If you are naturally releasing your egg and we're just helping with a HCG trigger, which I did a factor fiction on recently when we looked at helping with an ovulation trigger in addition to natural cycles, or when you're doing IUI cycles with letrozole or Clomid, it is probably sooner. It might be more like 24 hours. So in those cases, you want your IUI the day after your natural surge, but you want your trigger at the time of your surge. So you need an ovulation kit to determine that. Do you recommend that pregnant patients receive the Tdap vaccine? Is there any risk to the fetus? Is there any link to autism? Oh, Jillian, you're killing me. Okay, so that's a great question. I am not an anti-vaxxer. Let me specify that right out at the beginning. I totally believe in vaccinations. My kids are all vaccinated. I'm a huge fan of Gardasil. I'm actually the cervical cancer colposcopy screening lead for our region. So there is no question that vaccines can be tremendously advantageous and should be used in appropriate circumstances to protect people all over. God knows right now, is there any more important time to develop a vaccine than something that will get rid of this darn COVID-19 virus? Having said that, the risk of having pertussis or whooping cough, more commonly known, for a baby is that the baby can actually be hospitalized for a very long time. So my very good friend, Carrie Mayrand, tried to hammer this into my head when I was arguing with her about it. So the babies do stay in hospital for months sometimes if they get it. And the reason they want us to vaccinate is to prevent those babies from ending up hospitalized. What's the actual number? It's 13 per million. So it's not a frequent occurrence, but when it happens, it's kind of a disaster. So yeah, I'm now recommending it because even one baby in the hospital for months is something that we should all be trying to prevent. But it is a pretty low risk for the baby. Is there any link to autism? None that we know of. Is there any damage to the fetus? None that we know of. So that's all I can tell you about that. When do you recommend starting aspirin for a frozen embryo transfer? You can watch our Fact or Fiction on aspirin. Do it before you start. It's important to start it before, like while you're going through your cycle. Ahead of time is important. Willing to pay. Catherine, if you are willing to pay, let Sarah know and she'll just arrange for your shipping. Not a problem at all, sweetie. Okay, back to this side. Completely no alcohol. Yes, completely no alcohol. Alcohol is a class 1 carcinogen. It causes 7 different types of cancer for sure, and 4 more that they suspect. And to put it into the best perspective I can, I worked in a lab multiple years in my career in university. When you need to clean the lab to get rid of all biological contaminants like viruses and bacteria, we use alcohol because it kills everything. Hand sanitizer, all of us are pounding into our skin. All of this stuff is all containing alcohol in order to kill all of the viruses and bacteria and get rid of the COVID. Why would you take something in you that kills live material when you're trying to create live material? No amount of alcohol is the right amount of alcohol. Also, sex the night before IUI. Pretty discouraged or okay? Discouraged. The day before. So 2 days before the IUI, it's fine, but not the day before and certainly not the night before. You can do anything to her that you want, but she can't get you to ejaculate. Sorry. Hi, doctor. How do you feel about gauging ovulation by monitoring taking temperature? Abandon taking temperature. It is notoriously inaccurate, super frustrating. It causes male erection problems because they hate the stress, and it actually causes nothing but frustration. And it's not nearly as accurate as doing the ovulation test strips. So just use the test strips. Much more accurate. Can you ovulate without having your period after being on Lupron for 4 months? Yes, the first one can occur without having a period. So that is very possible. How do you thin out the uterine lining for FET? Lining too thick for transfer. Don't take estrogen. So that's the easiest way. If weight is a factor, you got to reduce your weight because your body may be producing estrogen naturally, but there is no easy way to reduce the lining thickness. A lot of progesterone can, but that can create problems of its own as well. God, we're running out of time with all these questions. I love you guys. If I run out of time, I apologize. Send them to us and we'll maybe answer them during the week. I can throw up answers to questions as posts.
If they're watching on YouTube, let them write their questions in the comments section and we can respond to them as well.
Did you guys hear that? So if you're watching on YouTube, you can write your questions in the comments section and we can respond to those as well. I had IUI this past Friday, but never got a prescription for the daily aspirin. Can I just go pick up some from the store and start, or was it not prescribed for a reason? It depends on your history, and we don't always use it for IUI. We use it more for IVF, but you can use it. There's no harm in doing so. You don't need a prescription. It's just over-the-counter baby aspirin, 81 milligrams. So, yep, you can grab it. And if you want me to grab you a prescription, don't hesitate. I can do that. I'll be a guinea pig for dual trigger IUI, LOL. Sounds good, Katie. I'll be happy to do that. Hi, Dr. Victory. Is it normal that after miscarriage in mid-March, period is not back yet? It can be, although that's starting to get a little bit late. So come in and we'll do some hormone tests and an ultrasound for you. That's easy. Just call the office. Okay. Does HGH, human growth hormone, help with egg quality? If so, how long before start of IVF cycle should you start? Is it similar to DHEA? Okay, so it is not similar to DHEA. They are completely different. I can't tell you specifically if it helps with egg quality, but it must be doing something to improve live birth rate. Nobody knows how it works. And there are different protocols, but they are all typically done either significantly before or during the time of your stimulation for your egg retrieval. And it's always done just for IVF, never for insemination. It is quite expensive, and it's also off-label use. Hi, Dr. V. If you are a female over 40, what do you recommend? I had 2 with C-section. Would love another baby. Wow. Okay. That's too vague for me to answer. I'm sorry. I need way more information. Are you struggling to have a baby now? Why are you struggling? Is it male factor? Is it female factor? I can't really answer that one. There's all sorts of things we can do for you, or even just you can do for you, but I need to know what's going on. What do you tell patients when you diagnose them with unexplained infertility? So we have loads of questions about unexplained. So I give the same answer every time. That has to be one of our fertility basics. So we will have a fertility basics post on that. Make sure you like and subscribe. We'll be dealing with all these things. So unexplained infertility has only 4 different treatments that have been proven to work. Letrozole or Clomid with insemination, IVF, injectables with insemination, or surgery to see if there's something that we are missing. Those are the only 4 things. Now, there are some patients where we do additional testing. For example, unexplained infertility can be caused by viruses in your uterus, like human herpes virus 6. It may be related to men with high sperm DNA fragmentation. So there are some different tests that we might do for you. But overall, aside from more testing, there's only 4 treatments that are known to work. Don't try anything else. It's a total waste of time. Okay, so what is the difference between the 2 types of IUI your office provides? That is a great question, and thanks, Mary Lou, for highlighting that. That's a great question. Okay, so we now offer 2 types of IUI. We have our conventional IUI, which is a centrifugation process. So sperm goes onto 2 layers of a chemical, gets put in a centrifuge. The poor little guys go winging around at a gajillion miles an hour, and we get this little pellet at the bottom of the tube, which now means the sperm have been stuck at the bottom of the tube, and all the semen and the proteins and hopefully some of the dead and not so good sperm are kept up in the gradient. We then take that pellet and we resuspend it in what I like to call Red Bull for sperm, so it makes them go really fast. It's basically a sperm energy drink. And then we respin them again to get rid of any of the gradient chemicals from the last wash. And then we take that and put it back into a new little droplet of the sperm Red Bull, and then that's what goes inside you. The good news, it works quite well. The bad news, it actually has been proven to increase the sperm DNA damage. So if you already have high sperm DNA damage, that's probably not the best technique for you. The alternative is to use this other technique, which is called Zymo. So that is Z-Y-M-O-T. And Zymo is a technique where there is a specific little plate. You put the sperm on one end, you put the media on the top, and you stick it in an incubator. The sperm then have to swim through the media and through the sort of whole process of getting to the egg, to the other side. And by doing so, they have to go through this filter layer. Somehow the filter has been designed in a way that it screens out 90% of the sperm with high DNA fragmentation. So you get this very pure sample on the other end. The numbers look kind of daunting because it's much lower sperm count than what you get from the centrifugation process, but it works amazingly well, and we are seeing higher success rates with it. We're going to use it for all of our IVF patients, and for the insemination patients, we are recommending using it when you have high sperm DNA fragmentation or if you want that little boost in success. It is about $100 per kit, so we do charge $100 more. And it involves quite a bit more time and effort than just doing the centrifugation process. So that's the answer to that question. Okay. How low should your BMI be in order to do a tubal reversal? Ideally, at least less than 35. For sure, less than 35. Less than 30 would be even better. If you are over 40, do not try doing a tubal reversal. It has surgery risks associated with it. Okay. Hi, Dr. Victory. I hope all is well. Me and my husband have been thinking about trying to have another baby, but no time soon. But we fear about having another miscarriage. What will be our chances this could happen again? Is there anything we can do so it doesn't happen again? Yeah. So aspirin helps. Vitamin D helps. There are things you can do. It depends on multiple factors. So age, the shape of your uterus, infections, that vaginal and uterine microbiome. You need a lot of testing if you're trying to avoid a miscarriage. So come in and let me see what I can do to help you. If you're not with us, then you have to kind of explore all of the different things that are available. Is it normal to get your period 3 months postpartum while exclusively breastfeeding? Does this mean I'm ovulating fertile? It can. Certainly if you are getting your period, it may mean you're ovulating. Breastfeeding is not protection against conception. So be careful with that, Beth. Okay, and I think we got two more over here. What is the difference between I went through that one. Okay. Can HGH be used in natural IVF for better quality eggs? Again, we don't know, Audrey, if HGH actually alters egg quality. We just know it improves live birth. So it can be used, but whether or not it makes a difference, I don't know. Would you consider someone with Hashimoto's a high-risk pregnancy? How would the care of someone with this diagnosis differ? So, yeah, you're not a high-risk pregnancy. You definitely don't need maternal fetal medicine consult in Canada. In the States, it probably doesn't either if you've got a good OB, but it's very different between Canada and the US for OBs. We certainly wouldn't recommend it for Canadian patient. However, you're not high risk past the first trimester. You are higher risk of miscarriage, but once you've gotten past that, there aren't any significant increases in risk. So we otherwise would treat you normally, but you need your thyroid monitored very carefully. You need your dosage titrated carefully through the whole pregnancy. Is there anything that can improve viability of eggs? Have good ovarian reserve for age 40. You got 14 plus eggs in an IVF cycle. Thumbs up for you. 4 5-day blasts, but none were normal. Oh, I'm sorry for Hannah. There are things you can do, but the problem with age and genetics is that the older you get, the more the number of eggs are genetically abnormal. And to the best of everybody's knowledge, you can't really alter that. There are some tricks to getting better embryo quality with the genetics to be appropriate. So I was talking about it earlier in the show. The ratio of recombinant to urinary FSH should be half. So you want half recombinant, half urinary, and that will improve your chances. Okay, guys, we are down to the wire. Katie, I'll answer your question because you know I love you and it is actually the last one. Can Zymo be used with frozen sperm? That is a fantastic question. And the answer is it depends on whether your sperm has already been washed or not washed. So if you've bought washed sperm, probably not a great idea. And if you bought unwashed sperm, yes, it should be doable, but I will double check with Fariba, our spectacular and amazing and very lovable embryologist and lab director. She is our lab director. So I hope you guys enjoyed the show. Make sure you like and subscribe. Super important. Like, subscribe, or the other way around. And we will see you all next week for another amazing show. We're also going to have our fertility basics and a review program coming up very soon. So you'll see us trying kits and websites and apps and all sorts of stuff and reviewing them and talking about whether or not they make sense. Have a great night, guys, and we will talk to you again soon. Stay safe.